Great, thanks. Well, welcome to World Coma Day. My name is Claude Hemphill, and I'm a professor of neurology at the University of California, San Francisco, and one of the co-chairs, along with Daiwa Olson, of the Curing Coma campaign. And this is our fifth World Coma Day, and one of the things we all recognize is the first word in World Coma Day is world. And so we want to make sure and emphasize the opportunity for sharing perspectives and questions and comments and directions globally on World Coma Day. And so one of the things that we've prioritized this year, and it was really a great experience last year, so we're repeating it, is the opportunity for each of our global chapters to have a session that is really their own, where they decide what questions to ask and have the opportunity to share with folks all over the world. And so this is the Middle East and North Africa chapter session, and I'm really privileged to be part of it. So I'm just going to turn it over to you, Jimmy, and let's see what you think.
All right, great. Thank you, Claude. It's always a pleasure and honor to join, and this is a wonderful, reminder for all of us to discuss this important topic that I think is gaining more traction, especially for us at the bedside. And we really appreciate the opportunity that you give for all the regions, and specifically for, I would say, our emerging region in the neurocritical care field. I'm not going to talk about geopolitics here, but even in neurocritical care and critical care, it is emerging and it's gaining tons of traction. And especially that many of us, I'm just going to classify myself as a bit older, maybe Samia recently, so we're all training abroad, coming back, and we are slowly but surely growing that field in our respective countries, and this is a great honor. So I'll start just by the introductions, and I'll pass it on to my colleagues, and then we'll get started. My name is Jamil Dibu. I am trained in the US. I was a neurocritical care fellow at the Cleveland Clinic in Ohio, and I was privileged to be recruited, it's been now 9 years, to Cleveland Clinic in Abu Dhabi and set up the neurocritical care unit. And it's been an incredible journey, see how much we've come along in Abu Dhabi, specifically UAE, regionally, in terms of neurocritical care as a field, from education to my practice to conferences, and the attention, specifically with the support of the Neurocritical Care Society. It's been tremendous, and I see it firsthand with the impact on the patients. And the World Coma Day is just another added layer for us to take it to the next level while we approach these patients. I'll pass it on to Abdul Rahman and then Samia.
Thank you, Jamil, and thanks to this kind invitation. Abdurrahman Al-Faris. I'm an intensivist, a general intensivist, not specifically neuro. I've trained in Canada, between Montreal and Toronto, and I'm privileged to have recently hosted the 6th regional chapter or 6th regional conference of the chapter of the NCS in Kuwait. And get to know the whole group who was there, and I'm happy to join in this conversation. Thank you very much.
Thank you, everyone. Thank you for adding me, honestly, to this group. I'm so happy. So I'm Sami Al-Mazroui. I'm a recent graduate, actually. So my background is emergency medicine. I completed 5 years of training at McGill, and then I did 2 years of neurocritical care at the Montreal Neuro Institute. So I just graduated 6 months ago, and I'm currently working at Khawla Hospital, which is a major trauma center. And we see like a big number of patients like subarachnoid, stroke cases, TBIs. So it has been like 6 months, but it feels like 6 years for me. Thank you.
All right, Sana.
Okay, good
if you can
afternoon.
introduce yourself.
Yeah, sure. Good morning or good afternoon, everybody. I'm Dr. Sana Al-Khawaja. I'm a ICU consultant and chairperson. I have graduated from London, Ontario, Canada, critical care now, and I am the Chief Medical Services for the Center of Excellency, which cover emergency and critical care as well. We don't have a specific neurocritical care, but we are taking care of neurocritical patients in our main unit. Thank you.
Wonderful. Claude, do you want to kick it off, or you would like me to kick it off with the panelists?
Go ahead. Go ahead.
Yeah.
I know you submitted or set forth several questions that would be good starters. So I want to see where you start.
Yeah. I mean, look, I'll start maybe by just throwing out there one of the things that is the self-perception of, maybe I'll ask the group panelists and my colleagues here. I mean, what do they, when they see a patient, unresponsive patient on no sedation, irrespective of the pathology, or even factoring in the pathology, what is the general perception? I would say not just for them in particular, but also of the team, of the nurses, of the ancillary staff, of their colleagues that may not be well attuned with neurocritical care or patients with brain injury. Is this just like a hands-off, oh, this is comatose, unresponsive, no chance? Or there are certain ways you look at the patient and no, there's still some hope. And what are these basically? And what do you hang on to for these patients to keep chasing them, pushing the families, pushing the ancillary staff to keep hope in these patients? Maybe I'll start with Sami. What have you done for the past 6 months?
I would say it depends, first of all, because I do both emerg and ICU. So my background is emergency. So when you tell me in emergency room, someone tells me this person is unresponsive, so I will evaluate, assess. So it's different. But when I'm talking about the neuro ICU, we are talking about a patient I would assume maybe TBI, intubated for a long time. So it's totally different. So it goes back to what is the etiology, okay? What has been done for this patient so far? Any reversible things that was tackled, like any metabolic issues that has been looked at. So I always go by like system, okay? That's always my approach, especially when I'm starting a week. So let's say this patient is already there for 3 weeks. So I'll start from A to Z. Okay, so what has already been done? Was anything reversible excluded before going ahead and talking to the family? So that's number one. And I would say my major challenge when it comes to the team is that they always use GCS for everything. So we are working on that part because GCS is not always the best answer, okay? So they keep mentioning GCS during daily rounds. And so I'm trying to work on that aspect. Maybe we need to use other tools to evaluate these patients, not just the GCS. It's not enough.
Maybe come back to this GCS point because I have a feeling it's a regional thing that we have. Abdurrahman, go ahead.
Definitely, it's a regional thing. So it's always I get where your question is going. It's always kind of dark when you round on a patient and their brain doesn't function, or that even the glimmer of hope when they are awake and responsive is not there. And everybody, it feels like it's a doom. All the nurses, the whatever therapist that we have in the unit, or the extended interprofessional team, they always feel that an unresponsive patient is doomed never to respond. And here where you have to use your tools that are expanding in critical care to ascertain whether there is a glimmer of hope or not. And it's difficult if you work in an environment where when you don't have these other tools that might be of an aid. We have continuous EEG here, we have pupillometry, we have other things that we've recently invested in our unit that are not available in every single critical care unit. So it's a bit difficult to depend on your basic assessment tools and examinations to determine outcome of patients. And you know, there are so many things that we don't know. I remember my training in Toronto concentrated mostly advanced cardiac and respiratory therapeutic interventions, that my time spent in neuro a critical care unit or in a unit that provides attention to the brain was minimal throughout these 3.5 years or 4 years that I spent in my fellowship training. So I'm sure there is a lot more that is out there that can give us a glimmer of hope when somebody is unconscious or unresponsive. And I feel there is so much investment that we can do in that aspect, especially in our region when we come to tools as what we mentioned, like GCS and others, where people always throw a number, and the number, if it's horrible, then you think of a horrible outcome instead of having that little bit of a hope.
Maybe I'll ask Sana just to combine these two things because combining the GCS number and tools. I mean, what would you do, Sana, if you take on service and you have a patient that's comatose, been like that for a while? You know, you can see the lack of hope for this patient. Is there anything when you round on these patients or you take on service, you look at them and it's like, why are we losing hope? And you'll ask a few more questions. Or what would you want to know to make sure that truly there's no hope or not? Like, where is hope for you here?
Okay, I think first of all, we have to differentiate, as Samia said, where we are seeing this patient. Because both of us working in emergency as well as critical care. So if this patient, we saw him in the critical care area, management and prognosis, more investigation would be different. But if we are seeing this patient at the emergency, they just brought him from home. We don't know for how long this patient was comatose, what was the comorbid, what was the resuscitation at home, what he was resuscitated even during the transport to the hospital. These kind of patients, especially if they are elderly, multiple comorbid, nobody was with them at home, they did not receive a good resuscitation. So these people, they will not have that much good prognosis. So I think we need to deal with them in a different way than the patients which we are seeing in the critical care. Because a critical care patient, most of the time, they are well monitored. So even if they suddenly became unconscious, we know what is the underlying diagnosis. We have in our mind what could be the differential diagnosis, what other modality of investigation we need to do, how we can monitor these patients. So we are not depending on the GCS or anything in the critical care, but unfortunately in the emergency department, this is the first thing we will look at, especially if we don't know these patients are unconscious for how long.
I echo almost everything that's been said. I would probably put it in a neurocritical care field, wider umbrella. And specifically by that, I mean, my approach to coma is a lot of times, I try to be obviously more optimistic. I try to give second chance to when I take on a patient that's been labeled as he's not going to wake up or she's not going to wake up. A lot of I always just keep in mind, although I've been here 9 years and we have an incredible team of few are neurocritical care board certified, etc. But our staff overall, it's unlike like big centers say in the US, where everybody's a neurointensivist. All the nurses have been maybe there for a while or been trained and groomed in high volumes. A lot of our nurses, for example, ancillary staff, even some of our medical staff or physicians, they don't wear the hat of a neurologist, and I feel as a background, or a neurointensivist in training, and I think that makes a difference. And a typical scenario would be, I'll just mention, for example, one particular case that we see maybe once a month on average, that many of you have encountered, say, NMDA encephalitis, for example. And because we've seen a handful, at least in my career, that's done well, but we've kept going and going for a long while. Whereas because There's an army of neurologists and neurointensivists and capability to monitor them and give them all these treatments. And there's aftercare as well, which is another point that probably I'm going to pivot into shortly. Whereas here, seeing them, not on NMD encephalitis is tough to understand. It's rare to see, and once many months pass by, everyone loses hope in general. So, but then if you have a neurologist or neurointensivist that have seen it, or a nurse, this experience helps. The understanding of what is NMD encephalitis, the lack of actual brain injury in a young patient, is a recipe for not losing hope. Advanced monitoring, continuous EEG, all of these definitely factor in when I approach these patients. Now, of course, it's easier said than done than, when someone's labeled as comatose, you have diffuse anoxic brain injury. It's available. It's there on CT, on MRI and CT, and multiple EEGs have been done. That's one aspect. But then this is the more challenging aspect that I find it hard and to kind of not lose hope. And I think that takes a lot of what we've been doing over the years is continuous education, the presence of all these experts that come in, the availability, as Abdurrahman was saying here as well, acquiring an ability to involve all the resources that we have to monitor these patients. So that's been a key factor for us to approach patients with coma in a more judicious fashion. And another point, maybe I'll just ask, just in general, as information, and because I think that factors in coma and outcomes, is how is in your respective countries. So I don't know that we've mentioned out loud. Samia is in, I think we did mention in Oman. Abdurrahman is in Kuwait. Sana is in Bahrain. I'm in the UAE. I'd love to know in each of your respective countries, in terms of, you may not know in terms of outcomes, but after the ICU care, what are the capabilities? What are the availabilities of long-term care, rehabilitation, the ones that you would imagine they will make a difference in the patient's lives, or is it still developing or not really truly available as you wish it to be? And do you think it factors into coma care? Maybe Sana, if you want to go ahead, take it on.
Okay. Regarding the rehabilitation, I would say in Bahrain, it's still we need to work more on that. We have a small rehabilitation center, but it's not mainly for neuro cases. It's mainly for ortho cases. Why I'm saying it's make a difference? Because with comatose patient, the rehabilitation is different. You need a multidisciplinary team. You need a psychiatrist, you need a physiotherapy, occupational therapy. You have to understand the mental of these patient, plus they need some work on the cognitive function as well. So unfortunately, we don't have this. I think we do have a gap between the transition between the acute care setting when the patient they are in the hospital and we are doing everything for them, even the physiotherapy or the rehabilitation at the hospital, it's good. But when they are discharged, going to our home, they do not have the good rehabilitation. We don't have this. There is some private sectors which we are doing it, but funding is another problem because these are too much expensive, and the insurance is not covering all these. So the family, they will end up with either bringing some kind of physiotherapy at home, but this is not the best for rehabilitation for these kind of patients. So I think we need to work more in Bahrain regarding the rehab because it's really make a big difference. A lot of people which they have enough funding, usually they are going outside. They are going outside for specialized center, and we do see a good prognosis when they are coming back. So we need to work more on this in Bahrain.
Two very valid points that I will share also my thoughts on at the end, which I think they fall into category of coverage and access and availability of centers and especially to comatose neurological patients. Abdurrahman, do you want to share what in general the landscape in Kuwait is?
It's not much different than what Dr. Sana mentioned in Bahrain. It's a bit scattered. There is a rehab center that feeds from all the hospitals, all the general hospitals in Kuwait, and goes there. But it's a typical governmental sector at the end of the day. it caters for the masses, but without a specific, as far as I know, without a specific route specifically for only or patients with neurological problems that they would require specific rehabilitation for that. So we've specifically in Emiria Hospital we've seen that gap, and in every major hospital in Kuwait, you have a rehab medicine department that can provide that aspect for you. But we've noticed that the patients that we discharge from critical care are are a bit lost. And from our training in North America, where the long-term outcome clinics and following these patients up for a longer time and seeing how they do from a physical perspective, emotional, cognitive, etc. We've started a clinic here in our hospital for the past 2 years or so, and we're trying to grab these patients and make sure that if they are lost in medicine or lost in a RESP clinic, or they don't have access to a psychiatrist who can help them come through their post-critical illness period, we're trying to grasp these patients. It's a bit difficult to follow everybody, but we're trying to figure out the best criteria that we have that we can follow these patients up. But for sure, more can be done. We have a very active treatment abroad service that when something is lacking in Kuwait, patients are sent abroad for whatever specific therapy. A lot of people go to the Cleveland Clinic at Abu Dhabi for liver transplants, for example. But they go elsewhere in the world. And we do, as Dr. Sana mentioned, we do see improvement in their neurologic recovery once they have that intensified therapy. So hopefully one day this investment can happen in Kuwait.
How about you, Samia? It's interesting. I mean, I love that you guys established that clinic. I think you're one step ahead of many of us. I think that's definitely one step towards the right follow-up care for these patients. Samia?
I would say it's similar to Bahrain and Kuwait. The only difference is our ICU, we have like acute and then chronic. So most of these patients, I would assume the comatose, they will end up in the chronic area. And when they're in the chronic side, we already have like a multidisciplinary team. So we start working on applying for a rehab center. But again, it's like we don't have many rehab centers. So we have like a government rehab, but most of them are private. So that's the challenge. And as my colleague said, they're not like neuro rehab centers. So we actually need a specific neuro rehabilitation centers to help this kind of patients. So that would be like a plus. Yeah. And we also
I echo. Go ahead.
the same thing, but mostly the family members, they decide to take their loved ones abroad.
Yeah, and I think it'll be a good segue to talk about families and because that's definitely something I would feel it's going to be a unique point compared to elsewhere. But yeah, I do echo more or less the same. The bigger, I think if we want to bucket them is so in terms of demographics, I think if we start with that, at least in UAE, and it may be less as extensive in terms of demographics as the other neighboring countries. So as you know, it's only 10%, 90% are expats. And 90% of expats, a lot of them are maybe, labor workers, etc. So access to care or these center of excellence care, while it's covered for the acute care by the government because of lack of access or good insurance, but there is the aftermath. It's not covered. So a lot of times, if they have access, we do have long-term facilities. Yes, they're not, your best neuro intensive rehabilitation that you want to see, but there are some. But access remains a problem, and so in my heart, I do feel a lot of times we do a lot for the patient, and that now it's up to rehab. I wish we've had more, and I do feel it would have made a difference. And I can imagine Coma is a very niche, particular subset of patients that require probably even quite a bit of advanced, post ICU care. And I do wish we will get to that point. I think in the grand scheme of things, in terms of healthcare in general, this region has come a long, long way. And Coma after ICU care, I think recognition and awareness, I think it'll come naturally. And so this, in terms of insurance, demographics, and access and availability. And maybe I'll just throw in that last question, and if Claude, go ahead afterwards. If you find something that you want to ask us about in this region, please throw it out. But I'll mention, and I'd love to hear everyone's experience, and I'll share mine as well. How do families? How is the interaction with families in patients with coma? And I mean, I think many of you, most of us on the panel, maybe had the experience abroad, and we came here. How much of a difference have you seen it when you break the bad news, for example, for families, or how difficult it is to talk about coma, what is coma, their understanding of coma, and how much of a bigger challenge it is to talk about the aftermath. And I'll pose a simple question. It sounds funny, but I think in terms of hope, do you think they bring hope to coma patients while we bring them bad news, or they agree with you? Which one do you think it is? And I don't know, Samia, go ahead.
I liked your last sentence when you said they bring hope. So my experience, it's totally different from North America. So families here, they're more, I would say, optimistic. They are hopeful. No matter what you tell them, they will always say, no, there is hope. Okay. And so they'll be willing for more aggressive treatments and everything just to keep their loved one like alive, no matter what. I would say the difference between where I was and now, there it was more of like quality. They would ask you, okay, what would be the quality of life? He's comatose now, but what do you expect? Will he recover? How much will he recover? You know, quality of life is one. But here it's more about prolonging life, I would say. So they will hold on to anything just to keep that person like supported. So that's one aspect. And I would say, I don't know if it goes with the same topic, but for us as physicians, no matter how much you describe things to them, we don't have other options. Like, okay, the only thing I can do is no escalation of therapy, but we don't have withdrawal of treatment. Okay. So at the same time, my hands are tied, you know? So I'm telling them, okay, the prognosis is bad. I don't think so. He'll wake up, he won't do what or what, and so on. But then I will still support that person, till the end. Okay. So that's.
So this is very interesting because I think it's multifaceted. Maybe we'll just do it one by one while we're on this topic, because it's a lot to share. So do you think families probably are more hopeful in general for coma patients than the actual staff, you would imagine?
Yes.
Yeah, I would echo that.
Yeah. Anything
Then do you think that the law or the lack of withdrawal of care, or the lack, I would say, even take a step back, we don't really see a lot of advanced directives. You know, this is lacking here. But do you think, and then your hands are tied, I think all of us, our hands are tied, and we continue giving care, for the most part, a lot of good care for the bad prognosis or the comatose patients. So have you seen patients so far, and I'm going to ask the questions for the rest of the panelists, that you probably in Canada, you would have withdrawn care a long time ago, and then you were surprised by the outcome because we actually continued care. And I'm like, in general, this guy shouldn't survive that way or wake up. And then he woke up. Did you encounter that already?
Yes, I had to email my staff that case. Definitely, if that person was like in North America, they'd be like, stop here. But we continued. That person woke up, yes, bedbound, but at least has eye movement, communicate with the family. So for the family, they're so happy. So for them, that's all that matters to them, you know? So
exactly. Sana, do you want to comment on maybe
Yeah.
the aspects of what's allowed and not allowed in Bahrain in terms of, futility of care, withdrawal of care, all that stuff, and how does it affect your approach to coma, and especially with the families?
Yeah. Unfortunately, in Bahrain, we don't have even end-of-life care. It's not with withdrawal. We're not talking about withdrawal. Even end-of-life care, it's not accepted in our society. Although in our neighborhood, like Saudi, they do have end-of-life care. They have at least stop further management. But in Bahrain, we don't have anything like this. And this really affect our decision about the patient. Because as Samia said, in Bahrain, I think it's in all the Gulf, I don't know whether they have a guilty feeling or they have denial feeling. When you are telling them that the patient is having this and this, and we are thinking prognosis is poor, they will say continue all kind of support which we are doing. Sorry, they are not concentrating about quality of care at all. All what they care about is seeing seeing their loved one in the front of their eye, even if he will remain bedbound, not talking, not doing anything, vegetative state, still they want him. That's why we start. I mean, in our ICU is small compared to the big hospital. In our hospital, it's 1,500 bed, and our ICU it's only 25 bed. So that's why we have limited patients which we are taking them to the ICU, we are triaging them. This kind of patient which we feel prognosis will not be that good, he have multiple comorbid, and the family, they are not realistic. We don't take them usually to the ICU because we cannot do much. And after that, as Samia said again, we cannot stop further management because there will be some legal issue. So we cannot say will not further escalate the treatment because the family, they will not agree. So it's really very, very big issue for us in Bahrain. And the second question, whether we have seen patients, they did not withdraw and they improved. I have seen this, but it's in young patient, trauma, not stroke, trauma patient, young. They do have good prognosis. Even at the beginning, you think it will not, but I mean, young patient, what we have seen, usually they do have good prognosis.
Abdurrahman?
So I would, I wouldn't disagree with whatever have been mentioned so far, but I think, the attachment to loved ones here is quite strong. I will not dismiss, how they feel here, and I would not say that people in North America and other places in the world where we've trained are not attached. Different people have different attachments to their loved ones. But and also you would I had countless encounters with relatives where they think when they think even brain death is reversible. I remember even prior to my training in North America, I was taken to court for investigation because we've declared a patient brain dead. And then when it was time for their heart to stop, the family objected for us for not resuscitating them. And they brought us case reports and other things from other parts of the world where, patients wake up. So there is this strong belief that, it's easy when you say you have cancer and Mets. It's easy when you say you have end-stage heart disease with an ejection 5%, and you cannot function. But to tell someone that, oh, you have a catastrophic injury to your brain and you're never going to wake up, people don't, easily comprehend that. I don't think it's only in our region. I think it's a global issue, but we deal with it differently. So that's the challenge. It's a constant challenge. It's a constant challenge, as you mentioned, when you have your staff who believe in that there is nothing more or no glimmer of hope that you can do here, while the relatives are extremely attached. So that's a huge challenge. We do similar to what Dr. Sana mentioned. You don't have abundance of ICU beds, so if you wanna reserve your critical care unit for the reversible cases and have a appropriate outcome, then, certain cases like this, you wouldn't bring them down to the ICU, unfortunately. You would leave them intubated, ventilated in the ward, and whatever outcome that happens there, unfortunately. Withdrawal of life support is not available in Kuwait, and even CPR and consenting for that is not. But we recently, maybe the past 2 years, had a ministry-wide policy that provides comfort care, for patients who are meeting a certain criteria that committees inside the hospitals can agree upon, that you would provide comfort care for them, and not withdrawal of life support, but more comfort pain management, and making sure that period at the end of their life is really easy and not with suffering. So it's different. Everywhere is different. When I trained in North America, we used to have relatives round with us in the ICU. They would be standing in the ICU, they would be interacting. I thought I would introduce that when I came back, but I faced this, a huge challenge, not only from the relatives who, you would have not only one person join you in the round, but 20. But you would have a problem with your colleagues, the other intensivists in the unit, or the whole team, where they would say, no, what are you trying to create here? A monster for us? So it's a bit challenging. It's a bit challenging, but what I do in my practice is I talk to people all the time, whether it's my colleagues in the unit or whether it's relatives, and I'm honest. We have to be honest in whatever we see. We don't know everything. We sometimes, these cases, fortunately, I haven't given a bad prognosis to a patient or a relative, and then that patient woke up. That would be a nightmare for me if it happened. But people do have that glimmer of hope, especially when it comes to the brain.
Yeah, I echo everything that has been said. Nothing is different. I would maybe just say, let's start with, same in terms of healthcare policy, or what can we do, can we not do. I think more or less what is being done in Kuwait, because of the recent advancement in cancer care, palliative care, allow natural death. That's our word for DNR. That's allowed to be said. But if I think the only condition that is to be able to do that is the family has to say yes. If families say yes, we can extubate the brain dead patients. We are allowed not to do escalation of care or no CPR. So that's, I believe, good advancement that's been introduced recently. That's definitely there. But going back to our coma patient and the family, I think the families and the culture, the existing culture and the families have really struck me. One of the major things that struck me when I started practicing here is there's no such thing as advanced directives. The culture is, obviously, we hang on to the last breath. It doesn't matter if it's a declared dead patient or comatose or whatnot. And since the law, at least in the past, did not allow you but to care for who's in front of you, irrespective of their diagnosis, and the family is always hopeful, and there's nothing legal that supports you to do less. So we don't have the self-fulfilling prophecy. And I know we have, we have an honor to be moderated by Dr. Hampel, the originator of ICH score. I can bet your score predictions will change once you come and apply them here, because here we do have, you see them through and through. Like, there's no self-fulfilling process. Like, every paper starts, we don't really know the prognosis because of self-fulfilling. We don't have that because we don't withdraw care. You have to care for them till their heart stops. So and when you start seeing patients that, as I think Samia mentioned, that they did wake up, you didn't expect them to. Granted, they're not really super functional, but you see the families, for them, it's a major, it's life-changing. They woke up, they just looked them in the eye, or irrespective of what they've done. And in Cleveland, probably on admission, we would have made them comfort care. And understandably so. They've seen it before. They know what comfort care is. They know a quality of life care. So it's a multifaceted thing. It's a culture change. It's a major culture change that has to go through. In our region, it is going to take many, many years to accept these practices, accept what advanced directive is, to understand what truly coma is. There's, I think, a big component of literacy or healthcare literacy that needs to be done in the region for us to be able to utilize the word coma, for the families to understand coma, for us to be eloquent enough to explain what coma is. But also, we need to capitalize, and I think I feel like I'm on that bandwagon of not losing hope, because the patient is there, the families are there, and I'm having to round on them every day. And I find myself a lot of time repeating the EEG. Again, not with the diffuse anoxic brain injury, not with things that I know truly in my heart that they're not going to wake up, but the iffy ones, the one hemisphere ones, the I'm not really sure why they haven't woken up. I have a patient, it's been over a year of NMDA encephalitis, 30-year-old. The brain MRI has not changed in terms of volume. We've done all the rounds of IVIG, chemotherapy, you name it. She's still not waking up. She's still twitching. We've done numerous EEGs, but I'm still going at it. Although all my staff have given up, because when I see a young patient with normal brain, I will not give up. But it takes culture, it takes time, it takes experience, it takes advanced providers to really support the mission of keep hope from our end, not just from the families. And I think it's a major plus that we have here, that our family at this point, that families and healthcare policy are not developed enough to withdraw care. So I think in this part of the world, I think coma hope is a bit, I would say, on a balance higher than in North America, to be frank with you. And I'll leave it to you, Claude, if you want to ask us any questions after this discussion.
I would like to add one point, please, before.
One
of the other issue which we are facing in Bahrain, we don't have something called power of attorney. So there is no one who will take the decision. Sometimes they will say, for example, sometimes they will say the husband, sometimes they will say the sister, sometimes the father. Nobody. So you will face the whole family, and each one of them have his own opinion. And sometimes we do have bigger problem because they will split into two parts. Some of them with the support and further management, the other understand little bit, so they will say, okay, we can have some discussion about end-of-life care. This is really big problem which we are facing, that there is nobody to take a decision. Everybody, the whole family, as Dr. Paris said, you will face 20, 25%. They are all of them coming to discuss the case. Thank you.
So I think this is so important for, obviously, you guys are discussing it within your own region, but it's so important for us to understand globally, because we all work within the context of our culture, and I'm curious a couple of things. So who cares for these patients? They may still be in the hospital, but are you guys or the folks that are working in the intensive care unit or have some neuro knowledge of these conditions caring for these patients longitudinally if they are in the hospital indefinitely, but not in the intensive care unit?
Yeah, I mean, for us, if we have a challenge, which is not often, that there's no home for them. We treated them, they didn't do well. They don't have insurance enough to go to a long-term facility. Our social worker works with the embassies to repatriate. So as long as they're present, they are in the hospital cared for us, and they are getting the full care. Absolutely.
In Kuwait, if they are in the ward, not in the intensive care unit, then they're under an internist. They get whatever consult service that comes and see them. So neurology would be involved, and they would have not one-to-one nursing, of course, but they would have every services that you provide for a ward-based patient.
So go ahead. Yeah.
It is same for us. The only thing is we don't have internal medicine as an admitting service, so they will always be admitted under either neurology or neurosurgery. Yeah.
In Bahrain, we are exactly same as Kuwait. If they are in the ICU, it will be their care will be under the critical care team. When they go to the ward, they will be under the internal medicine.
So, yeah, a interesting question comes up, and as we've certainly expanded neurocritical care worldwide and recognized that we are facing the same diseases, but we're facing them in the context of different cultures. The self-fulfilling prophecy thing, that was a culture thing in where I live, and so you say what is the problem that the culture brings, not problem, situation, thing to be addressed. And in our setting, it really was we don't have enough opportunity to see how people are doing long term in terms of if they're just being supported because of this particular issue, which I would say the self-fulfilling prophecy was more of a cultural issue than a medical issue. So I'm curious, a couple of things that your situation brings as an opportunity. One, I'm wondering, so if these patients are there and they're there long term and they're there in front of everybody, are they getting a lot of stimulant therapy? Is there something, well, they've been here for 3 months. Why don't we just go ahead and put them on methylphenidate? Why don't we just kind of see what happens? Are there opportunities to really either formally or is it happening informally to test these interventions that are being done that are potentially accessible? We're not talking necessarily about deep brain stimulation or expensive situations, but are folks saying, yeah, might as well?
I would say we do, but using our clinical judgment. I think at the end of the day, when we change shifts, every physician takes on, we have to review the patient, and it doesn't matter comatose or not. They're there. We have to round full force and their full code. We do, sometimes resort to amantadine, modafinil, stuff like that, and outside of the context of TBI, etc. We do, but it is restricted. And I would say, just coming to your point, which definitely is food for thought. I mean, in an ideal world, the problem, I would imagine it, World Coma Day is a challenge, I would say, in North America, has its own challenges, probably is the self-fulfilling prophecy. If you come to our side of the world, you don't have that problem. It is just the through and through care, like maybe the aftercare or the longitudinal care. So if you merge these two, I would say you will have an ideal, if you merge that culture, I mean, you put them and then you provide the resources. I think it'll be great for all these comatose patients that we give up on, but we shouldn't give up on. But yeah, to answer your first questions, we do in certain clinical scenarios that we think there's still hope and they're here with us.
The other thing is, I don't know, it's a question for me to ask everyone. We have a lot of coma cases, but I was trying, I'm a new staff. I wanted to find if we have a coma registry, but we don't have in Oman. So I don't know, maybe having a registry would help us move forward. Because I don't know what happened with the cases in the past, the ones who went to rehab, home. It's good to have a way to follow them. I don't know if anyone else is having a coma registry.
I'm going to say it's really interesting.
Comment on, I think, sorry, Abdurrahman, I think led with Yasser and a kind of registry about TBI, was it? I think he can comment maybe on research as a whole. And I think I can maybe throw one comment is the biggest challenge is what we see in all research here is just the continuity or the follow-ups because of the, at least UAE, the expat community, the lack of access. Once you discharge them, there is almost no way on earth to just get them to come back or call them even or reach them for an outcome, and which is a biggest limitation. But maybe I think Abdurrahman led this project before and can comment a bit more about his experience.
So we're involved, in 2 centers in Kuwait in the Compose trial. So we've had involvement in certain patients, but we don't have a Kuwait-wide registry of all these patients. And this is what we're trying to, as I mentioned earlier, with our long-term outcome clinic. Although patients have to be, selected, appropriately for that clinic. We're hoping maybe we could get more information there, but it's very difficult. It's very difficult to ascertain that long-term outcome once they leave your facility and your unit. Yeah.
This registry issue came up in the Asia Oceania session a few hours ago on World Coma Day, and I think this is sort of a common theme. I'm going to be interested to see what the other regional chapters have to say about that, because I think this is a theme that's coming up, and the opportunity to, as you said, combine the experiences based on the cultural approaches in different parts of the world. A registry is would bring that somewhat. Yeah. Can I ask you another quick question? I know that we're getting to the top of the hour, but I wanted to ask. I'm going to preface this by saying something that happens culturally in our own, in my situation, related to hospital caregivers, and this could be nurses, it could be other physicians, it could be especially non-neuro physicians that care for these patients. So we talk about cognitive biases, and one of the things that we've sort of realized is that when we have patients who, well, let's just say when we have patients that get better, so they get better. That's great. Everybody sees them get better, and we recognize that, and that's very positive. We have patients that pass away early, either from withdrawal support in our context or just from their disease. Then they are no longer being seen by any of the providers because they're not there because they've died. So it's really only the patients that don't get better, that stick around, that are seen over and over by the providers. And we found that this reinforces a notion that patients don't recover, because those are the only patients that providers see over and over and over again in the long term in the hospitalization. And so it's created this cognitive bias of a perception of lack of recovery. And I'm wondering if that resonates at all, or is not your experience. I don't know if I said that the correct way, but you understand sort of what I'm getting at. It's only the patients that remain deeply comatose.
Yeah, if I may add, the patients that stick in your unit for the longest period of time are the ones who have brain injury. And if you switch a week from one person to the other, then you're stuck with those same patients, and it's exactly to your point. You feel, oh my God, it's always a bad prognosis. They're always bad. They're always sticking. They're never leaving. And while the other pathologies have their share of quick reversibility sometimes, or or the outcomes are maybe better. I don't know. I'm always biased there, but that drains you sometimes as well. When you always see the same, it's a catastrophic ICH or a big stroke or an brain injury post-resus or something like that. It's they make you feel that these patients never recover. And that's the downside of it, unfortunately.
My comment would be, Absolutely. I mean, you make a great point, Claude, and a lot of times I would love to put it. I would love sometimes to get my hospital leadership say, and the regulators leadership, and just highlight this category of patients, because the ones that do well, they're in and out. The ones that don't do well and pass away in a sort of way, they're in and out. Then the ones that bothers the most our hospital and is an economical burden on the hospital and the country are the ones that are there. And so instead of looking at, how can we bring in more patients, but how can we, how about we focus on these patients? Either we all put our, scientific head and use our evidence base, and can we really help them or not? And let's take it full force in terms of coma evaluation, go above and beyond, or let's take it to the other extreme. Well, let's implement a law backed by the government that, okay, these patients, we investigated, exhausted everything we can, and we cannot help them, and let's find them a pathway to exit the hospital. Be it, if we think they need neuro rehab, then we need to invest in a neuro rehab. If not, then just a mechanism to expatriate them. But they end up staying there, and these are the ones that increase your length of stay. And obviously it bothers, or it is a negative burden on the country and the hospital. So these patients, we drag our feet when we round on them. They are the ones increasing your length of stay. Perceptions are different, cultures are different, regulations is wishy-washy. And I think there's definitely room to put them in either side. Either you continue care, maybe do better, or just have them exit to the right place instead of adding economic burden and cognitive burden on the staff as well.
Yeah.
Yeah, if anyone has any other comment or
Agree
last.
with what you said. It was very beautifully said, honestly.
Yeah, absolutely.
Well, I mean, as a just maybe I wrap it up, if you don't mind, Claude. I just want to thank you, the NCS, of course, my dear colleague Yasser, and everybody behind setting us up and giving us the chance for the MENA chapter to highlight our perceptions, challenges, and how far we've come along. I think every year we discuss this. I'm sensing we are doing a bit more and more every single year. And just the mere fact that we're discussing coma care for us on this side of the world is still, it's an exception. It's exceptional because we are thinking about these patients, and we are putting our best resources and our staff members towards this care. And it's only a matter of time before we continue to give our best and see differences. And we want to capitalize on the lack of self-fulfilling prophecy at some point, and hopefully we will be able to. So thank you for the opportunity to join, and I appreciate my colleagues for all these insightful comments.
Yeah, I have to say this is great, and I learned so much during this session, and this is exactly why we have World Coma Day, and I think that being able to continue to bring in these broader discussions, I think benefits all of us and ultimately benefits our patients. So thank you guys so much. And I did want to mention, and I put something in the chat. One of the other aspects of World Coma Day, in addition to our live sessions, is YouTube archive. And so we've had folks from all over the world submit a variety of different videos. Some are educational sessions, some are science sessions, some are what we call shout outs, where folks from different ICUs or rehab units send in just a notice of support. We also have stories of hope from patients and families who have described their journey, and these are open and available on YouTube. So and they'll remain up indefinitely. So please check those out and pass them on. And thank you so much for this session, and I look forward to our next discussion.
Thanks a lot.
Thank you.
Thank you very much.